little bit before 7. Sweet. All right. So tonight we're going over soft tissue injuries. Again, we're continuing through our trauma module. So what can you guys tell me that you remember from last week? What's our acronym, for example? What's our mnemonic for remembering what we're looking for when we're looking at trauma patients as far as finding injuries? DCAT, BTLS, good. All right. So real quick, what's the D? We're gonna go one right through the other. We'll start off with D. What's D stand for? Deformities, good. Yeah, discoloration. Well, not so much discolorations. You could say dislocations, because then again, you still wind up with the deformities portion. Um, let's see.
Is it contusion?
Contusions, good. All right. Yeah, not cuts. We're gonna actually talk about cuts tonight, but there's another term for that. What's A? Abrasions, good. All right. P?
Puncture.
Punctures. All right, good. All right. So then now we just have B, T, and L and S. So B is burned. What's T?
Tenderness.
Yep. And tenderness is the one thing that we can't actually just look at the patient and see. All the rest of the stuff you can look at them and see it, but tenderness you actually have to feel and kind of make your own judgment based on that. All right. What's L? Lacerations. Good. Now that's what cuts are. We'll actually refer to them as lacs or lacerations through the course. All right. And then what's the last one? Swelling. Perfect. Swelling and deformities can sometimes be confusing. Um, that's okay. I'm not gonna get bent around the axle if you guys mix the two up when you're doing your DCAT BTLS. It's just make sure that you're checking for that. All right. So anyway, we're gonna move into soft tissue injuries tonight. Now, and we're not talking about punctures and everything like we were before or blunt trauma. We're talking about actual cuts to the skin, injuries to the skin itself, not necessarily anything that would damage internal organs, even though we are going to consider that as well. Let's get through these slides. Soft tissue injuries are common. This can be everything down to the paper cut all the way up to, like taking deglovings, if you've ever heard of avulsions or anything of that sort. Those are the kind of injuries, the skin tissue injuries that even make me queasy. I mean, they're not fun to look at. That's where, like, if a ring gets ripped off of a finger and it takes all the skin with it, and you've just got some muscle and bone sticking out, and that's what you're looking at. That can happen to your fingers, your hand, your wrist. If you've ever seen the second Terminator movie when he cuts through his forearm and pulls it off to show the robot underneath, that's what avulsions are. That's kind of the extreme end of what we're going to be talking about tonight. So that's why these things are so common, though. Not every injury is going to be that level. A soft tissue injury could just be a paper cut or a burn, any of those kind of things. These can be life threatening. Usually it winds up being life threats if it's massive body surface area that's a problem. A lot of times it comes down to infection and other issues like that. Long term effects wind up being the problem if it's not a life threat in itself. But these are just skin injuries. So don't let them distract you. Remember, we'll give you scenarios and you'll see in the real world where you've got a patient that looks just completely jacked up 6 ways from Sunday, and it's really hard to remember sometimes to start with the airway when what's in front of you looks like a mangled up victim from it or something. So don't let these things cause tunnel vision. Sometimes you have to take a step back, take a deep breath, look at your patient, and be like, all right, well, he's jacked up, but I'm going to start with BSI, and safety, and move into my primary. Soft tissue of the body can be injured through a variety of mechanisms. So when we talked about blunt and penetrating trauma, Those are two of your major ways. Barotrauma can do it, which is commonly seen in blast injuries when we talked about those primary, secondary, tertiary injuries. Um, the barotrauma from that primary shock wave can do damage. And then burns may also result in soft tissue injuries. Soft tissue trauma is a common form of injury. It happens to almost, if you've gone, actually, it's something funny. We teach first aid as well, and we do the American Heart version of it. One of the scenarios that plays in the video is a guy that gets cut on a piece of glass, and this is a full-grown dude. And one of his lines is, "Never thought something like this would happen to me." Like, how you made it that far in your life to make a serious statement like that. I realized it was fake for the show, for the DVD, but still, I can't not snicker when I hear that. Open wounds account for approximately 4.1 million emergency department or ED visits in 2011 alone. And wound care is one of the most frequently performed procedures in emergency departments across the United States. Most of these injuries require basic interventions, wound irrigation, which is not something that we typically do in the field, but you may be required to do it depending on if it's going to be a problem for your patient and trying to stabilize them on the way to the hospital. So an example of that would be if there's a hazardous material on them, we'll irrigate it. We're not really irrigating to stop infection, we're irrigating to stop further damage. But anyway, we also do dressing, bandaging, and limited suturing. Not necessarily us. I know that as in the military, we were taught how to suture, but as a normal EMT, even a paramedic, that's out of our scope because if we start trying to suture things in the field, the hospital's going to wind up having to undo it anyway because they have to do what's called debridements, where they clean that wound out. And I mean, we've wasted our time and we've caused pain to the patient if we start trying to suture in the field. Death is often related to hemorrhage or infection. Those are your big two concerns when we're dealing with these kind of injuries. Again, our role is more about the hemorrhage. The infection is something that the hospital will typically deal with, and they'll deal with it through antibiotics. To assist on stitches when I did my ER rotation. Yeah, oh yeah. Yeah, stitching is actually pretty fun. I've done stitching in pig labs. I've done stitching in the emergency room at Keesler when I was doing my OJT there with the military. Not something I would want to do all the time, but it's still pretty interesting. All right. When the skin barrier is breached, invading pathogens can cause local or systemic infection. Long term, again, we don't have anything to deal with that. So soft tissue injuries and their complications can often be prevented by using simple protective actions like, wearing cut resistant gloves. They're not really puncture proof. I don't know of anything that's puncture proof. Y'all can y'all think of something? I know you see the gloves out there. They're like you can rake the knife across it and it doesn't cut you, but I've never seen something that you couldn't puncture. Not to say they don't exist. I just haven't seen any. But yeah, simple safety precautions a lot of times will protect people from skin injuries and even you yourself as a responder, because especially when you're dealing with trauma, remember whatever hurt them may still be there. It could be anything from a needle stick to a saw that could still be running. One of my best friends has a pretty jacked up finger. He loves showing it off to kids and scaring them, but um, it basically he lost a fight with a bandsaw, and he laughs about it now, but he almost lost his finger, so it's not really that much of a laughing matter. Um, so if that's the case, like if you were the EMT that responded to him when he did it, one of your first things to do would be turn the saw off. Some other issues, we talk about lacerations being the soft tissue injuries, but when you think about some of the other things, like say burns, for example, another effective strategy to prevent getting burned is don't get near the heat source. If we're talking about an uncontrolled structure fire, then smoke alarms can be a lot for proactive approaches because they'll typically go off and alert you to get out of the building before the flames ever reach you, which is good because the smoke will usually kill you first. Controlling the temperature of hot water heaters, enforcing building codes that regulate electrical and construction practices. That's out of the scope of this class. That's our fire inspector courses. And nobody really likes fire inspectors. I hate to say it. All right, but anyway, um, did I miss a slide? All right, here we go. The skin is the body's first line of defense against external forces and infection. This is your largest organ. If anybody ever quizzes you on what's the largest organ in the body, it's not the liver, it's the skin. It is relatively tough. It comes in layers. It is still susceptible to injury, obviously. Injuries range from simple bruises and abrasions to serious lacerations and amputations. You can actually, if you're going to talk about the skin specifically, the extreme end would be something like an avulsion. Amputation would not just be your skin, that would be the bone and everything else as well. Injuries may expose blood vessels, nerves, and bones. And, fun fact about bones, um, typically your bones don't hurt. Like when we put in an IO on a patient, a lot of times they don't really hurt from the bone. They'll feel the pressure of it, but they're not screaming in agony because their bone hurts. Um, there's a condition that typically has to be met for you to feel pain specific to a bone. Anybody tell me what it is? I'll give you a hint. The only time it's really going to happen is if you have an open fracture. This is just a GWS thing I learned in high school, actually. So bones don't really have pain receptors. It's like if you press down on your arm, you're not gonna hurt. You're not gonna go, "Ow, my bone hurts," um, unless something happens to it. And it usually is because it happens during an open fracture. Something has to be present around the bone for you to really feel it. I mean, no, that's all right. Like I said, it was a GWS thing my teacher taught me in high school. But air. When you expose your bone to air, like an open fracture or an amputation, you will feel excruciating pain from the bone itself. But normally, even when you fracture, if you have a closed fracture, for example, or you give a patient an IO, which is an interosseous um, injection point where you screw a needle into their bone and you're going to push fluids that way, the contact with the bone actually doesn't really hurt them that bad. They're going to feel pain through their skin and their muscle, but the bone itself isn't really registering pain. If it's an open fracture and it's open to air, that's a different story. They're usually going to scream bloody murder because then it is extremely painful. Um, just little gee whiz stuff. Anyway, in all instances, no matter how bad the injury might be, your job is to control bleeding first of all, because remember how vascular your skin is. Especially the deeper you go, you run the risk of cutting arteries and veins. Um, you want to control their bleeding, prevent further contamination due to decrease the risk of infection. We can't fix it, but we can stop it from getting worse, or at least we can slow it down. Protect wounds from further damage and apply dressings and bandages to various parts of the patient's body. So your job is pretty simple. If you've ever had to put a band-aid on yourself, that's pretty almost all you're going to do as an EMT. You're just doing it on a much bigger scale. All right. So if I ever told you in a scenario that you had a patient with a pretty severe laceration to his, we'll say his forearm, um, when you got to the point of taking care of that, I'm not going to say you're going to start with this because you still got to start with your ABCs. But when you get to the point of dealing with that laceration, you're basically just putting a band-aid on it. You're trying to control the bleeding, make sure your bandage is clean. That controls infection spread, that kind of thing. Skin is thinner in the very young and the very old. They're more likely to have abrasions that go a little deeper and wind up causing more problems. And skin is also thinner on the eyelids, the lips, and the ears than it is on, say, like your scalp, your back, soles of your feet. Your soles of your feet and your palms are usually really thick, really rough. They don't have a lot of nerve endings, and the reason being is because you're smashing them in the ground all day long. A lot of times you don't want to feel that kind of pain, and then it'll hurt to walk. All right. So the skin has two principal layers, the epidermis and the dermis. I was always taught three with the subcutaneous layer underneath. I'm sure a lot of you guys were as well. Um, they still consider the subcutaneous. I mean, they didn't like get rid of it. They just don't really consider it skin. All that fatty tissue below the dermis is just, I don't know. They still teach it with skin. Like I'm in an anatomy class in college, refreshing some of my sciences for another degree for my own personal progression. But um, they have since taken that subcutaneous layer out of being a dominant layer of the skin. They still talk about it, which is good because there's some injections and some medications we give in that area, so can't just ignore it. But um, the only two you really need to know is the dermis and the epidermis. The epidermis is a tough external layer that forms a watertight covering for the body. It's actually pretty thin, just a couple of layers of cells thick. The dermis is the inner layer of the skin. This is a lot thicker. There's a lot more layers to it. This is where your hair follicles, sweat glands, and sebaceous glands are going to be rooted. Blood vessels in the dermis provide the skin with nutrients and oxygen. And then your skin covers all the external surfaces of the body. Various openings in the body are lined with mucous membranes. The mucous membranes provide a protective barrier against bacterial invasion, and they're mostly, you're going to find them around, say, like your nostrils or around your lips, that sort of thing. Sometimes they'll secrete a watery substance that lubricates the openings. Sometimes they don't, like your lips, for example. If anybody's ever had dry lips, it just depends. It can be any number of things that would stop it from happening. But when they do dry up, that's when problems can start to occur. They'll get chapped. They start to kind of crack, and then you've got breaks in the armor of your skin. But they usually, when everything is right, they stay wet. So here's a picture of your skin. You see the epidermis compared to the rest of it is still pretty thin. Um, the epidermis typically doesn't have a lot of blood vessels in it. These cells are usually dead, and they just make a barrier. A lot of your blood vessels are in the dermis underneath it. So if you nick your epidermis only, you might be able to see it like a little cut, but there'll be no real blood or anything of that sort. If you start to bleed, that means you've dug into the dermis underneath it. And I like that this picture still shows the subcutaneous layer as well. All right, talked about that. Any break in the skin may allow bacteria to enter and increases the possibility of infection, fluid loss, and the loss of temperature control. Any one of these conditions can cause serious illness and even death. So if they get out of hand, now we're dealing with life risks. Not all breaks in the skin are that bad, but not all of them are that good either. Let's see. There's 3 types of soft tissue injuries. Let me get to the right slide here. There we go. All right. So we have closed injuries. This is damage that occurs beneath the skin or the mucous membrane. Sometimes, if you've ever heard of puncture wounds, that can be an example where the wound goes beyond what the external layer took damage with. Blunt force objects can cause this, but for the most part, your actual top layer of skin stays intact and the damage is done underneath. Sometimes a bone break can cause this, where the damage is coming from inside the body rather than outside. Then we have our open injuries, and this is where the break in the skin actually makes it all the way to the surface. So outside substances, say like staphylococcus, which is what causes staph infections, those things can get in. Other bacteria can get in, and we start running into issues with infections as we go on, as our patient goes on through their recovery. And then we have burns. So they classified, this used to be a chapter of its own, burns, but they've put it into this now, which, jury's still out on how I feel about that, because I feel like we have to rush it by doing that. But there really isn't that much to it, so it's all right. But for burns, damage results from thermal heat, frictional heat, toxic chemicals, electricity, and nuclear radiation. It's not just fire. It can be any of those substances or any of those issues that can cause burns. For pathophysiology of your open and closed injuries, healing of the wound is a natural process that involves several overlapping stages, all of them directed toward the larger goal of maintaining homeostasis, where you keep the wet stuff going around and around, and you keep the air moving in and out. So the first step is to stop any bleeding. All right. So as soon as you get a cut, your body is going to start trying to clot it off. It's going to release platelets. The platelets are they're like hooks. As they are escaping the blood vessel, they should be hooking onto it, and then platelets behind them will hook onto the platelets that hooked onto the blood vessel, and so on, until they eventually close the gap. Um, that's the beginning of your clotting cascade. But our body doesn't like clots. We don't like scabs. We don't like any of that stuff. We try to break it. Our body releases chemicals that try to break that as fast as it builds because we don't want it to stay there, right? It's yes that you want it to stop the bleeding, but we want to replace that with like new tissue, real blood vessel tissue, so that it will function right. It's not, you don't want to just have the scar there all the time. But once that's done, now the body's going to start trying to deal with the other stuff because we're not bleeding out anymore. Now we want to try to fix whatever skin injury or bone injury or any of that sort, any muscle injury that came with it. So your second stage of healing is your inflammation. If you think about what your body is doing at this point, you're trying to rebuild something that broke. So if you picture a construction zone, your body is saying, all right, we need to rebuild. Let's send all of the materials that we're going to need, all the proteins, all that stuff. We're going to send it to the site so that the body has what it needs to make the repairs. Problem with that is that's a fluid. Everything's carried in a fluid, and so it swells up around the area. So swelling is normal. The inflammation is normal, but it will hurt. If anybody's ever been to the gym and that soreness you feel for a week afterward, this is the same thing. You've basically, in a controlled fashion, you damaged your muscles and their body's trying to recover. So it's going to send fluid to all those areas, which takes up space, starts pushing on nerves, things like that, and you wind up with the soreness. After a week or so, your muscles have recovered and the soreness goes away. Um, Inflammation ultimately leads to the removal of foreign material, damaged cellular parts, and invading microorganisms. Because not only are you getting the new stuff to rebuild where you've injured, but you're also sending white blood cells. They have to go in there and clean the area out as well. The body, it does a great job of putting itself back together again, as long as the injury is not too bad. To replace the area damaged in a soft tissue injury, a new layer of cells must be moved into the region. Again, that's where the swelling comes from. New blood vessels form as the body attempts to bring oxygen and nutrients to the injured tissue. And here's the thing, too. Let's talk about injuries. I know we're talking about skin tonight, but I want you to think about when we're dealing with the process of healing. If you hurt your muscle or your skin or any of that kind of stuff, um, the recovery is usually pretty fast because we have a lot of blood vessels there. But if you have a patient who was in a we'll say like you respond to a gym and it's a patient that is screaming about an injury that they've gotten, and it's in their joint, or they have a ligament that they hurt or something like that. That's going to take a long time for them to heal. You can go and pretty much tell your patient they're going to be recovering from that for a long time. The reason being is because there's not as many blood vessels in that area, so it takes a little bit longer. Your body does what it can with what it's got, but if it doesn't have a lot of roadways, there's not real easy to get all that stuff there to start rebuilding. But in the last stage of wound healing, collagen provides stability to the damaged tissue and joins wound borders, thereby closing the open tissue. If this is on the skin, a lot of times this is going to be what is actually your scar. Um, when you look at it like an old injury, like I damn near lost a finger about a year ago, and the scar is not that bad, but you can still see it. I don't know how got away with the scar as light as it did. Moving on to closed injuries. Your characteristics of closed injuries are a history of blunt trauma. So again, we're talking about injuries that don't break the top layer of the skin. This could be a broken bone that caused this. This could be getting hit with a flat object, pain at the site of the injury, swelling beneath the skin, and discoloration. A contusion is a fancy word for a bruise. So when we were talking about decap ETLS, yeah, like Joe, ooh, man, I feel bad for that guy. He's going to be down for a while. Yeah, his year's over. So when we talk about DCAT BTLS, when we say contusions, we're talking about bruising, and that can be technically that can be a small bruise, which hopefully nobody calls 911 for a small bruise, but they can get pretty gnarly too. If you've ever seen a seatbelt injury to somebody, it's a contusion and it's massive. Um, this is usually caused by bleeding beneath the skin that doesn't break the skin. So it's not going to bleed out, but it's in the skin, so you're going to see it. The epidermis remains intact, but the cells within the dermis are damaged and small blood vessels are usually torn. Bruising typically is not that big of a deal, but if it is a massive, massive bruise, then yes, that's kind of a big deal. The only issue is we really can't do anything about it, right? And as an EMT, a bruise is a bruise. The bleeding is there. There's no real way for you to stop further bleeding into their skin. So what's important about that is if it's that big of a bruise, say it's their entire abdomen, um, we want you to be aware of it because you're calculating blood loss. All that blood you're seeing is no longer in their vessels. Sometimes it can be a significant amount of blood. It's not necessarily the same as internal bleeding into their body cavities, but again, seatbelt injuries. This is one of the things when people talk about seatbelt injuries causing harm to a driver. This is usually what they mean. Um, that injury is better than what it could be without a seatbelt, but it doesn't mean the seatbelt's not going to hurt you potentially as well. A hematoma is blood that is collected within damaged tissue or in a body cavity. It occurs whenever a large blood vessel is damaged and bleeds rapidly, so we're going beyond the bruise here, and it is usually associated with extensive tissue damage. A crushing injury occurs when significant force is applied to the body. Think about somebody having a car drop on them or getting smashed between two hard objects. The extent of the damage depends on how much force is applied and how long that force is there. The longer they are underneath that force, the worse it'll be. Continued compression of the soft tissue will cut off circulation, producing further tissue destruction. The longer they go with that, the more damaging it'll be. And actually, if they are crushed big enough, if it's a big enough injury, sometimes you're removing the object that's crushing them could kill your patient. So we'll talk more about that when we get to boot camp. We'll probably hit on it more in this as well, but you don't want to just, it's not like removing a hazardous material. We don't want to hurry up and get rid of it. If they, let's say it's their entire lower body, both legs are crushed, when you remove it, the blood that was in their upper body that's been circulating for their head and heart, when you suddenly remove that crush from their lower body, all that blood's going to go down and try to refill the legs, and then your patient could actually stroke out on you because all their vitals are going to crash. When an area of the body is trapped for longer than 4 hours, crush syndrome can develop. All right, so when is really and truly, if you're on a scene of a crush injury, get a paramedic because they're going to need to do fluid resuscitation. There's a lot of other stuff that goes into crush injuries that you really can't do as an EMT. I hate to say it. It's just they haven't given. There's not a lot that you can do that's in the scope is the problem because a lot of it's going to be fluid therapy and things like that. Your knowledge can save their life, but you're going to be limited by your scope. So get a paramedic out there, especially if they've been in for a while. If they've crushing injury because they're in a car wreck and their engine block fell on them, got pushed into the cab, call a paramedic. They're going to be there for a while. Compartment syndrome. This develops when edema and swelling result in increased pressure within a closed soft tissue compartment. So imagine somebody that burned their arm real bad. All right. When the skin gets burned, it doesn't have that elasticity to it anymore. So when they start to swell, you need space to hold all that fluid. If your skin isn't elastic enough to stretch for you to allow the swelling, if you can't swell out, you're going to swell in. And when you do that, you start pinching off nerves, blood vessels. It stops the blood flow going to the end of the extremity, and then you run the risk of actually losing that arm or losing that leg because all the tissue is going to get necrotic because it's not getting blood flow. And if you don't fix it from there, it can be even worse because when you do finally start to restore blood flow to the area, all those dead cells that turn necrotic all that waste is going to be circulated through your body, and then you're going to have A lot of systemic infections coming through, and then that can be a life threat all by itself. There's a lot of pain, especially on passive movement. So if it gets bumped, that kind of thing, it'll hurt them. The longer the situation persists, the greater the chance for tissue death. And EMTs must continually reassess skin color, temperature, and pulses distal to the injury site if crush injury is suspected. So if you're worried about this, and compartment syndrome doesn't come on fast, this is something that takes a little while. One of the reasons why when we do our head to toe assessment and we're checking pulses in the hands and feet is we're making sure that there's nothing stopping the blood flow from getting that far. If you start doing your ongoing assessments and you're on the second or third round of doing it and suddenly you can't find pulses in the extremities anymore, that tells you that somewhere along the way on the arms or on the legs, they are losing the ability to pass that blood through. So now you're going to start to worry about compartment syndrome, or it could be something else. It could have been that they threw a clot, because sometimes that will happen. And you want to stay on top of that. Severe closed injuries can damage internal organs, especially if they're in the vicinity of what got hit. But also remember, like I said, that restored circulation, when blood starts coming out of those damaged areas, it can be carrying some toxic substances with it that can cause damage to the liver, can cause damage to your lymphatic system, your kidneys, all those organs that are trying to filter things out. It can even not just your filters, it can cause damage to your brain. Because you don't want all that bad, you don't want garbage basically floating around in your skull. You must assess all patients with closed injuries for more serious hidden injuries beyond that. All right, for your open injuries differ from closed injuries because the protective layer at the top of your skin is damaged. This can produce extensive bleeding. Can also, like I said, long term, not even really long term, but just longer than what you've got them for. There, you're going to have to worry about infection, mostly at the hospital. But like I said, if you can keep them clean, if you can keep them from getting worse off, then great. Address both excessive bleeding and contamination in your treatment of open soft tissue wounds. So we have four types that we worry about for open soft tissue injuries, and most of this is covered in your DCAT BTLS, but some of it is a little bit different. You have your abrasions and your lacs; those are from DCAT BTLS. So is your penetrating injuries, punctures and penetrations. The avulsions is the only one that's not really found in your DCAT BTLS, and that is a complete degloving. So it's a circumferential injury that strips the skin off. I'm pretty sure you're probably going to find a nice gnarly picture in these slides for that. An abrasion is a wound that is just a superficial layer of skin. It could be rug burn, road rash, any of that sort of thing. Lacerations are jagged cuts. So here you can see your abrasion. It just basically ripped off the top layer. These are your cuts. And sometimes the lacerations are intentional. If we're trying to fight compartment syndrome, we fight that by cutting the skin. We're creating lacerations, but they're in a controlled environment. We keep them clean. We're just giving the skin some room, some ways to expand. That way we can restore blood flow. And then here's your avulsions. An avulsion separates various layers of soft tissue, usually between the subcutaneous layer and the fascia beneath it, which is your basal layer that actually holds your skin on you, so that they become either completely detached or hang as a flap. Usually when I see, most of the time when I'm seeing avulsions, it's usually because somebody's ring got caught in a machine and they tried to pull their hand away and the ring just degloved their finger. I've seen entire hands get degloved from industrial accidents, but other than that, I haven't really, not in practice have I seen them anywhere else. I know you can get deglovings from your forearms, your legs, pretty much any of that, but I haven't seen it myself. Most of the stuff I've seen are smaller level. You can easily control the bleeding from some amputations if it's all the way through. If it's just a skin, same thing. Don't remove an avulsion. All right, so if it's there, like if you're looking at the picture on the right, how it's got that chunk of skin that's pulled away, we're not going to remove that. You just try to fasten it into place, because a lot of times the hospital may be able to control it. An amputation, which was next, is an injury in which the part the body part is completely severed, so it's beyond an avulsion. You didn't just remove the skin, now you've completely lost the finger. Usually amputations are controlled with a tourniquet, depending on where they're at. If there is massive bleeding, you should stop the bleeding first. And like I said, remember when you're doing your primary, if it's trauma related, it's okay. We're not going to fail you. And a lot of curriculums are teaching it now, where you actually put external hemorrhaging before airway, because if they've run out of blood, then what difference does it make if they're breathing? There's going to be nothing to transport the oxygen. Penetrating wound, we'll get to in a second. Well, actually, no, this is the end of this slide, isn't it? Yep, there we go. All right. A penetrating wound is an injury resulting from a piercing object like a knife, ice pick, splinter, bullet, poker from a fireplace, which I think I already told you all that story. These objects can damage structures deep within the body and can cause unseen bleeding. And if you're looking at your patient, when you're looking at their injuries, try to figure out what it is that caused it in case you don't see the weapon laying around. Just understand sometimes it can be misleading. Like I said, the guy that his wife beat him up with the poker um, looked like gunshot wounds. We were looking all over for a weapon with the cops, and we could not find a gun anywhere. Turns out she had got him with the poker. If the wound is to the chest or the abdomen, the injury can cause rapid fatal bleeding. It can also puncture a lung, and then they're not gonna be able to breathe. Impaled objects are objects that penetrate the skin, but they're still there. So if somebody gets stabbed with an ice pick, for example, be it intentionally or something accidentally impales them and is still there, then are we going to remove that in the field?
Never.
No, never. We don't pull it out. All right. Let's say it's a kid running with scissors and they fall and stab themselves. They're going to go to the hospital with the scissors inside of them. What we
Unless
do?
it affects CPR.
Do what?
Unless it affects CPR.
Right. Yeah. If they stab themselves in the chest and you got to do CPR, then it's coming out. Um, but for the most part, we're just going to stabilize it where it's at so that it doesn't continue to move around and do more damage in its vicinity, and then get them to the hospital. Stabbings and shootings often result in multiple penetrating injuries. If you are dealing with a shooting, don't just look for the entry wound. Try to find the exit wound if there is one as well. If there's not, that tells you the bullet's probably still inside them somewhere. Assess your patient carefully. Count the number of penetrating injuries, especially with gunshot wounds, and leave the distinction between entrance and exit to the physician. Just look and see if you can find it. If you have one injury, you flip them over and you find another one. You don't have to differentiate between the two. Just note that if there's, only two spots, one in the front, one in the back, one of them is going to probably be the exit wound, usually the much larger one. In a shooting, determine the type of gun when possible, but don't let this delay patient transport. Don't hang around just looking for a weapon. Sometimes patients and bystanders can tell you how many wounds were fired, but given the stress of the environment, their information may be unreliable. Somebody may tell you they've heard 5 or 6 gunshot wounds or gunshots, but when you're freaking out, sometimes you really can't tell the difference between the actual shot and, say, an echo. And just be aware that if it's a crime scene, you're probably going to have to testify. So make sure your report is very, very thorough. Blast injuries often result in multiple penetrating traumas. If you're close enough without any kind of barrier to stop you from that secondary blast, you're going to catch whatever shrapnel is coming at you. The mechanism of injury from a blast injury is generally due to the 3 factors. You have your primary, secondary, and tertiary. Again, your primary is the blast wave, secondary is your shrapnel, and your tertiary is you being thrown into something, either an object or to the ground or off a cliff or whatever it is. For your patient assessment, it's more difficult to assess a closed injury than it is to assess an open injury because that's just the nature of trauma. Trauma, our assessment, the more we can see, the better. But if it's a closed injury and you can't really see, all you can do is kind of try to estimate what might have happened based on what you can see. Anytime you observe bruising, swelling, or a deformity, or if the patient is reporting pain, the possibility of a closed injury should be considered. An open injury is easier because you can see it. So we always start with scene safety. Always, always, always. Does not matter what you're doing. Scene safety, BSI, scene safety, doing your scene size up. If you're dealing with trauma, especially where you think violence might have been involved, make sure you're on your A game with your scene safety, right? Try to figure out if the weapon is still on scene or the assailant is still on scene. Your patient may be violent as well, because a lot of times it takes two to start or two to fight. Otherwise it's just one guy getting his ass beat. Ensure the scene is safe. Call for additional resources. Cops should be with you on these. If it's something that you know is accidental, say like you roll up on a guy laying unconscious on the ground and there's a ladder next to him and you see no signs of violence, well, you probably don't need cops for that. Take the necessary standard precautions. Minimum of gloves and eye protection. Open soft tissue injuries can be messy because they're bleeding out, but should not take priority over more serious life-threatening injuries. No matter how much it distracts you, make sure you do your assessment in order. Get your life threats out of the way first, your ABCs, then move on. The only time you should jump straight to bleeding control is if it's an active hemorrhage. Be careful where you put your hands. Be careful where you place your equipment and how you package the patient for transport. If they're bleeding, cross contamination is a big thing. We want to make sure that we're not getting our equipment dirty, right? You don't want to put your blood down, or I'm sorry, you don't want to put your bag down in a pool of blood. Because if you're not paying attention and you do that, then you go back to your truck. Now you've contaminated your truck. If you put your bloody gloves, you start grabbing your equipment with bloody gloves and you throw them back in your bag, you've cross contaminated everything, which is no good. Try not to get into the habit of not washing your equipment. One of the grossest things that most people overlook and they never even think about is their blood pressure cuffs and their stethoscopes. A lot of times you're putting this on bare skin. There's no telling if anything is, and it's kind of high on the arm too. So you're getting home dudes BO, sweaty armpits all over your cuff. If they're bleeding, they may get some of that on there. Ugh. Clean your stuff. Look for indicators of your MOI as you assess the scene. They can help you develop an early index of suspicion for underlying injuries. If it looks like they're going to wind up having, based on what you see in your MOI, closed tissue injuries, especially if it's a car wreck, then be aware of that. And depending on how bad it is, those closed tissue injuries could be really significant. If they've broken their ribs, and those ribs are at risk of puncturing organs, that's a major concern. The MOI may provide information about potential safety hazards as well. For example, even something simple like a car wreck, you look at your car and you see it's all mangled up and your patient is still in the driver's seat, but you notice that the airbags didn't deploy. That's a threat to you as a responder. It's not an assailant, but the airbags could still deploy while you're trying to deal with the patient. So you take care of that accordingly. Use all available information to evaluate scene safety and consider whether additional resources may be necessary. When you get to your primary, we're going to focus on our life threats. So get your patient's level of consciousness, consider your C-spine, and move into your ABCs. Airway, breathing, circulation always comes first. Make sure is your patient awake and interacting. And when I'm dealing with airway, the first thing I ask myself is my patient able to maintain it on their own? If they are, then fantastic. If they are unconscious, then they're going to get an adjunct, either an OPA or an NPA, depending on how unconscious they happen to be. In fact, if my patient's not alert, if they're verbal or painful when I do my AVPU, if they're not up talking to me, I'm going to go ahead and give them something, even just an NPA. You can give an NPA to a person lucidly sitting there having a conversation with you. We used to do that to each other in the military. It's not going to hurt them. But if they're starting to get drowsy, give an NPA. If they're completely unconscious, try for an OPA. If they gag on it, well, that's a good thing. That tells you that their reflexes are still in check, and then take it out, give them an NPA after that. But you want to make sure that they have an open airway. Then I'm going to look at my breathing, and it's just a quick look. I'm not worried about necessarily an exact number. I just want to know, are they breathing at least once every 6 seconds or so? If they are and it looks good, then great. I can give them a non-rebreather or a nasal cannula. If it looks like they're not breathing well enough to support life, then I'm going to use a BVM on them. So you're kind of making your decisions, is it good enough or not? And then you're breaking your, what are you going to do based on that? So does your patient have any life threats? Closed soft tissue injuries may appear to be minor, but could indicate serious internal injuries. Don't get distracted from looking for more serious hidden injuries. If you look at them, you're like, well, this doesn't look bad. Or, they've got a massive open wound on their leg and they got some major bruising on their chest, but their chest looks, I don't see any open wounds. I don't see anything. I just see a bruise. The bruise is most likely going to be your biggest threat. The leg is, unless they're bleeding out, there's whatever, you can leave it alone. If the patient is alert, ask about their chief complaint. Usually they're going to point to what looks like the most gnarly injury and tell you that's the one that hurts, but there could be other injuries as well. Administer your high flow O2. You can always dial it back later, but give them 15 liters non-rebreather to start. If the patient has significant trauma, perform a rapid exam, look for your life threats, and treat them as you find them. Your life threats, not your twisted ankle, deformed, broken bones, that kind of thing. If the patient has obvious life-threatening external bleeding, then control that first, even before your airway and breathing. I'm glad they put this in here. Then you move on to ABC. So it is XABC here as well. Whoop, too far. We talked about airway and breathing. You're going to give them the oxygen, control their airway if you need to. Remember, when you're at this point, I want you to look at their chest. You're not doing your head to toe. Don't get that confused. You're looking for two specific injuries, and then you're going to move back to their head and continue your primary like normal. But expose the chest and look for either any punctures that could have perforated the lung. So if you have what's called a sucking chest wound, deal with that immediately. If they have a flail segment, you can try to deal with it. They've said that the bulky dressing and all that doesn't help. If you want to do something, that's fine, but I want you to at least make note of it and then continue on. That's really the only time you're going to leave your patient's head in the airway and breathing portion. And like I said, I want you guys to remember that even though you're going down to the chest to do that, that is not your head to toe assessment. So don't skip that section when you do your head to toe. You're still going to do your decap BTLS later on. Don't skip the chest, but I want you to just immediately jump down, look for those two injuries because those are damage to the lungs. For your circulation, quickly assess the patient's pulse rate, rhythm, and quality. So make sure they have a pulse and make sure the pulse is good enough. Determine the skin condition, color, and temperature. If they're cool and clammy, what does that tell you? If they're pale, looking all white like a ghost, sweaty, and you can see this from across the room, what does that typically tell you about your patient? Yeah, shock. All right, so if that's what you're seeing, you're going to be playing catch up. Unfortunately, we try to get there before they get to this point because we can't pull them back from it. All you can do is get ahead and try to stop it from getting any worse than it already is, which if that's what you're seeing, they're pretty bad. Check your cap refill time if you want, mostly for trending. If you don't bother with that, then so be it. Really, nobody's going to ding you for that. You may need to treat the patient for shock, depending on how long it's been since they got hurt. Make your transport decision, which if you had to do anything at this point or up to this point, they're a high priority. If they have an altered level of consciousness, they're a high priority. Depending on what you found in your mechanism, they're a high priority. And all of your assessments will be high priority. Everything we do in class. All right. At this point, you need to consider where you're going to take them. So not just do we need to leave right now or stay and play, but where are we going to go? Because when you're dealing with trauma, now we're talking about trauma systems, trauma hospitals, stuff like that. Remember that all you can do as an EMT and even paramedics, all you can do in EMS is stabilize your patient. We don't fix trauma. Surgery fixes trauma. So the question then becomes, can I stabilize my patient on my own? If you can do that, then take them to the nearest trauma center that can handle them. So you guys down in South Mississippi, if you're in, BFE or whatever, and there's a Band-Aid station between you and Forest or you and Slidell, if you can stabilize them yourself, don't worry about the Band-Aid station. Just go ahead and go to the bigger hospital, even though it's further away. If you're dealing with this patient, you can't stabilize them on your own and you need some help, that's when you're going to go to the nearest ER to get that help. They'll help you stabilize and then you continue on, or at least your patient will continue on, whether or not it's you that does it from there or not. As long as you can justify why you either went to or skipped the nearest ER, you're good. Types of patients who need immediate transport: poor general impression, altered LOC, dyspnea, which is problems with their breathing, abnormal vital signs, and I'm not just talking about a high pulse. I mean like their blood pressure's crashing, or they've got those Cheyne-Stokes breathing, that kind of thing. Shock and severe pain. As an EMT, because we can't give pain meds, severe pain is a reason to stop at the nearest ER, hurry up and get them there. Get them to somebody who can give them some pain meds, because severe pain will mess your vital signs up. Somebody's in a 10 out of 10, like a real 10 out of 10 pain, their respirations are going to skyrocket, which means they're going to blow off all their CO2. And now you're going to start to get metabolic issues. So pain management is a very real thing in EMS. For your history taking, investigate chief complaint, get your sample history, your OPQRST. Somebody unmute and tell me what sample stands for. Sing?
Symptom. Allergy, medication.
It's like, I don't think singing is one of them. All right, yeah, so all right, we got signs, symptoms, allergies. What else? Medications. Yep. Awesome. And then they've tacked an R to the end of it to make it sampler in some curriculums, but no, you're fine. You don't need to know the R. The R is risk factor. It's okay if you don't remember that, but just know that that's coming, so that by the time you guys do your refreshers, you're probably going to see sampler instead of sample. Any information you receive will be very valuable if the patient loses consciousness. But if you're worried about your patient losing consciousness, you may want to, E is events leading up to. You may want to prioritize your questions. You know, it really doesn't, for example, what they had for lunch is not that important if they lost a foot and they bled out. So you can skip that, or you might want to know what somebody's medications are if they're falling out on you or something, because you want to know if they took any kind of blood thinner. That's an important thing, especially when you're trying to deal with bleeding control. If the patient's unresponsive, ask somebody else. You can ask friends, family members, bystanders, medical identification jewelry if you can get you get your hands on it. Sometimes they'll have cards in their wallets. Just see what you can find. Remember, we talked about the smartphones. Typical signs of an open injury: we have bleeding. That's a major obvious sign that they have a break in the skin. Shock, hemorrhage, which is excessive bleeding, and disfigurement or loss of a body part. So if they have an avulsion or if they've had an amputation. I got some of mine. All right. Chronic medical conditions like anemia and hemophilia, as well as a host of other medical conditions, can complicate open soft tissue injuries. If they have hemophilia or anemia, that kind of thing, anemia, if you think about it, anemia makes them hypoxic and have a hard time breathing under normal conditions. So if they're anemic and bleeding, you're really going to be fighting to keep their O2 sats up. If they're hemophiliac, your biggest fight is going to be trying to get them to stop bleeding. Just in general, you'll be soaking rag after rag, dressing and bandage after dressing and bandage. It's just going to keep piling on, and they're just going to keep on bleeding. Secondary assessment. After you've evaluated your ABCs, made it through your life threats, then you can go back and do your detailed assessment. This is, to me, this is your head to toe, your full body scan, like it says there. It's also going to be your vital signs, and your history taking can be in this as well. For your head to toe, do your DCAT BTLS in each body section. So it's your head, your neck. I'm sorry, let me rephrase. It's your head, your face, your neck, chest, abdomen, pelvic area. So you basically went from the top of the head all the way down to their pelvis, straight down the middle. Then you check their extremities, and depending on where you're standing, you don't have to start with the arms. You can start with the legs. It just depends. But you're going to get all four extremities. Then you're going to get their backside, put them on a board if you need to, and move them. Um, that's where you're going to do your decap BTLS, but you're also going to be listening for breath sounds. Try to get an accurate portrayal of what their breathing is, and a couple other things. Like in addition to your decap BTLS, for example, when you're looking at their spine, you're going to run your fingers down the spine and see if you can find any step off, which is where one of their vertebrae might have got kicked out a little bit. Because if that happens, that puts a lot of pressure on their cord right there. And depending on where that's at, they could have some life threats from that, or it may just be that they can't feel their legs, or they can feel it but they can't move it, those kind of things. Assess their neurologic system. Easiest way to do that is your pulse motor sensory function in their extremities and your your pupils. Checking their pupils, make sure they react like they should. So like I said, listen to your breath sounds, determine their respiratory rate. We're kind of working our way into, oh, that's going the wrong way. Your vital signs. Once you've done your head to toe, you can get your vital signs. When we're dealing with trauma, your head to toe is pretty important because we want to make sure we're not missing any injuries that can cause life threats. So if your vital signs need to take a back seat in anything that you're doing, trauma would be it. If they're unconscious, if they're having a hard time staying awake, your vital signs become a little bit more important because now we're trying to figure out what's going on with their head, for example. But um, even then, you still want to make sure that you do a good head to toe, make sure they don't have any other major bleeds that didn't really classify as a hemorrhage before, but the longer they continue to bleed, the more of a problem they're going to cause. Reassess the vital signs to identify how quickly the patient's condition is changing. Signs that indicate hypoperfusion, which is shock, and indicate the need for rapid transport, tachycardia, tachypnea, so fast heart rate, fast breathing, and low blood pressure. You're going to see the tachy's before you see the low blood pressure. If you see tachy's and low blood pressure, they're not going to last much longer. They're probably going to crash on you soon. Some other things you may see: low blood pressure. Oh, wait, I saw that. Weak pulse. So if you feel out on their wrist and you can barely detect the pulse, that's a problem. Cool, moist, and bleh, yeah, good lord. Cool, moist, and pale skin, or cool and clammy, which is what I was trying to say. And then reassess with the patient's vitals every 5 minutes if they're unstable, every 15 minutes if they are stable. And those are just benchmarks. You can always do more if you feel like you need to. All right, take a 10-minute break while I get done with this mini stroke I'm having on how to talk, and be back at 7:05. All right, guys, we're going to get back on this. Keep on going. We're about a little bit less than halfway done with the slides, but once we start talking about how to stop these bleeds and how to bandage these things, we're going to start skipping through slides because a lot of that's going to be done at the boot camp. So for your reassessment, like I was saying before, if they are critical patients, you're going to reassess every 5 minutes. Stable patients, you're going to reassess every 15. You won't go wrong by reassessing anywhere faster than that. If you're not comfortable waiting 5 minutes, don't wait 5 minutes. Nothing says you got to actually set a timer for it. You just don't want to go beyond that. Make sure you document everything properly and just be ready, especially if it's a violent trauma. A lot of times you will get called into court just for them to get your side of the story and know what's going on. Check your interventions. Make sure that anything you had to fix in your primary assessment is covered, not failing or having any problems that you didn't foresee, and recheck your vitals, all that good stuff. All right, emergency medical care for closed injuries. Small contusions generally require no special emergency medical care, but you should note their presence to determine the extent of the patient's injuries. Even the bigger ones, there's really not a lot we can do with those. More extensive closed injuries may involve significant swelling and bleeding beneath the skin, which can lead to hypovolemic shock. But again, we can't really stop that. The injuries might not have had time to cause swelling or bruising, but eventually they will. Closely watch any area of injury throughout the time you're caring for the patient, no matter how minor it may look upon initial assessment. So what you'll do if you're doing your head to toe, for example, in one of our scenarios, and I tell you that you find a hematoma, or we'll go to the contusion. I'll tell you that you found a contusion that goes across both lower quadrants. All you're going to do is note it and move on. So that's what you would tell me. If you asked me what you saw and I told you that, you say, okay, I'm going to note it and then move on. Because what can we do? It's not like you can put a bandage on it and stop the bleeding. The bleeding's underneath the skin. Treat a closed soft tissue injury using the Rice's mnemonic. So rest the injury, ice, compression, elevation, and splinting. These treatments, think about sprained ankles, all right? Get them off of it. You don't want them continuing to try to run on it. Ice it to fight if you're going to fight inflammation, you're going to use ice. If you're going to try to relax a muscle, you're going to use heat. Compression also helps fight inflammation. Elevation fights inflammation, and then splinting just keeps it in place. It'll help a lot with their pain, and it'll stop them from making the injury worse. Signs of developing shock, anxiety or agitation, changes in mental status, increased heart rate, increased respiratory rate, diaphoresis, which is profuse sweating, cool and clammy skin, and a decreased blood pressure. If the patient exhibits signs and symptoms of shock, treat accordingly and aggressively, which is lay your patient supine, loosen restrictive clothing, cover them, and drive faster. Emergency care for open injuries, these are the ones that we can actually kind of do something about. So before you begin to care for a patient with an open wound, follow standard precautions, right? They're bleeding everywhere. You really don't want to get all that stuff on you. If it's a life-threatening bleed, assign a team member to apply direct pressure over the wound to control the bleeding. You can delegate. In fact, we highly recommend that you delegate and don't lock yourself into an intervention that you can't continue your assessment because you're stuck there. If the wound is in the chest, the upper abdomen, or upper back, cover it with an occlusive dressing, which we'll teach you about at the skills camp. You're going to control bleeding using direct, even pressure and elevation. Don't bother with the elevation. They took that out. If you remember when we talked about it the other night, it's just direct pressure, pressure dressings, and tourniquets. It's pretty much all you need to worry about. The whole elevation thing is bogus because if they have a blood pressure, then it doesn't matter if you elevate, they're still going to be bleeding. All open wounds are assumed to be contaminated and present a risk of infection. We again don't deal with the infections in EMS, but if we can stop it from getting as bad as it could get otherwise, then great. You did your patient a favor, and that's really what matters. Applying a sterile dressing reduces the risk of further contamination. Do not remove material from an open wound, no matter how dirty the wound is. We don't do the debridements. There's people that specialize in that, and they're at the hospital. Small wound surfaces without significant bleeding can be flushed with sterile saline prior to applying a dressing. So if it's just a little cut, you can just run some saline over it. Don't use garden hose water. All right, that's not because you don't know how clean their hose is. You put more dirt in it, that kind of thing. Use what's in your bag. If you don't have saline in your bag or sterile water, then just forego it. Wrap it, get them to a hospital. In most circumstances, hospital personnel will clean open wounds, not the EMTs. For abdominal wounds, an open wound in the abdominal cavity may expose internal organs. We call these eviscerations. If this is what you see, which is what's in the picture, we don't push them back in. All right, the organs are sticking out. Don't try to push them back in. What we do is take a bandage, wet it. All right, warm, wet bandage, put it on there, cover it up. That secures everything. Tape it down securely so that if any more organs try to push out, the bandage will hopefully hold it. Keep it wet. Don't let it dry because we don't want their organs to dry. But yeah, dry faster. If this is what you're dealing with, just get them to a hospital. Typically, your patient is stable with these injuries. These injuries don't cause them to be unstable by definition. If you have, obviously, if they are unstable, then you may have to stop at a hospital. But if this is it, if their vitals are good, they're talking to you, you can skip the band-aid station. Go ahead and take them to the higher level trauma center because you're going to need the surgeons to clean that up and put it back in. For impaled objects, occasionally a patient will have an object such as a knife, a fish hook. I've had a fish hook had to get out of me before. A nail. One of my wonderful coworkers shot himself in the hand with a nail gun when we were building trusses a couple of years back. Wood splinters, piece of glass, and impaled in their body, and these objects are typically still there. A wood splinter, whatever, pull it out. If it's a tree trunk, don't pull that out. Had an MVA like that this year. Was bad. All her guts were busted out like a youth. That sounds like a fun call. Um, when it comes to impaled objects, we'll go over the steps of this at basic, but the ultimate goal is to just stabilize what's the object. Um, so if they're impaled in, let's say it's scissors in the stomach, take a bunch of bulky dressings, line them around it, tape it down. If it's a piece of rebar, you may have to have the fire department cut it so that you can deal with it, right? You don't. It's kind of hard to get your patient in the ambulance with a 10-foot piece of rebar in them. Um, if their object is impaled in the eye, remember that your eyes move in tandem with each other. So if you want to stop the right eye from moving around, cover both eyes. So you'll stabilize the object the same, but when you're covering their face, like securing it down, cover both eyes. That way, if they have less urge to look around. If they're trying to look around with their good eye, you got to think that that's dragging the bad eye with it, and they're just causing more and more damage. Neck injuries, open neck injuries can be life-threatening because if you think about it, it's a lot of vital stuff that runs through your neck. There's not a lot of wasted space there. So if you've got anything more than just a flesh wound, it's going to be major. If the veins of the neck are open to the environment, they may suck in air. If enough air is sucked into a blood vessel, it can block the flow of blood in the lungs and cause cardiac arrest. This condition is called an air embolism. This is one of the ways that patients get it. Not to mention, if the artery is nicked, they're going to shoot a lot of blood out of their neck. And not only are they losing the blood, but they're losing the blood that's destined for the brain, which means that they're probably going to have a stroke. Apply manual pressure, but don't compress both carotid arteries at the same time. All right, so if somebody's bleeding out the right side of their neck, put your pressure on the right side, but not both sides because you want to still have some blood flow getting to the brain. Use caution with patients suffered from a neck injury, depending on the MOI involved. So use a C-collar if you can. Just try to get it as best you can. If they've got something sticking through the neck, you may not be able to use a rigid C-collar. You may have to take something like a bed sheet, roll it into like almost like a fat noodle, something that you can manipulate around the object that's in their neck, so that you don't cause any more harm. Small animal bites and rabies. Consider the scene and crew safety prior to and during the environment. If somebody got bit by a rabid animal, there's a chance that the animal could still be there. A small animal's mouth is heavily contaminated with virulent bacteria. Consider all small animal bites to be contaminated until proven otherwise. If you don't know, you don't know. Don't take it for granted. Just get treated, get tested, that kind of thing. Treatment may require debridement, which I know I've said it a couple of times, but that's basically where they go in and they remove any damaged tissue, they remove any grit, any dirt, anything, and there's basically just cleaning the wound, and it's extremely painful. Tetanus shots, antibiotics, and surgical repair. All small animal bites should be evaluated by a physician. A major concern in the spread of rabies, which is an acute, potentially fatal viral infection of the central nervous system that can affect all warm-blooded animals. You're not immune to it. I mean, we do have rabies. What am I thinking? Rabies shots that you can get where you, oh, Jesus Christ, this is not my night. Immunizations. Jesus. All right. Anyway, so the virus in the saliva of a rabid or infected animal is transmitted through biting or licking an open wound. And a way to know if something's got rabies, everybody's ever always heard of the foaming at the mouth. The only thing about that is that's kind of a late sign. So if that's what you're seeing, they probably got rabies, but they've probably had it for a while too. Children, particularly young ones, may be seriously injured or even killed by dogs. I know that when I was little, I got bit by a couple ones. I've actually got a scar under my eye where I almost lost it because I lost a fight with a Doberman when I was still wearing diapers. Um, the animal may turn and attack you as well as the responder. So don't enter the scene until the animal has been secured by police or an animal control officer. For human bites, the human mouth, more so than even a small animal's mouth, contains an exceptionally wide range of bacteria and viruses. Regard any human bite that has penetrated the skin as a very serious injury, whether you're worried about rabies or not. Just, like I said, it's kind of like expect the worst until proven otherwise. Any laceration caused by a human tooth can result in a serious spreading infection. So if you have to treat these, apply a dry sterile dressing, promptly immobilize the area with a splint or a bandage, and then provide transport to the ER for surgical cleansing of the wound and antibiotics. And a lot of times, most of your human bites are either going to be between kids or drug addicts will sometimes bite when they get combative. People that are having glucose issues where they're not in their right mind, altered LOCs, they can be causing that as well. All right, so for burns, we're going to spend a little while talking about burns tonight because this is something that you guys will deal with as EMTs that I want you to just understand that there comes a point where it's the treatment changes because you're not dealing with, oh, I touched a hot stove. You're dealing with, oh man, I was in a actual structure fire and I've got third-degree burns all over me. Burns account for approximately 3,400 deaths per year, and burns are among the most serious and painful of all injuries. This is usually a purely skin-related injury. So when we're dealing with burns and we're dealing with the treatment of burns, I want you guys to think about what your skin does for you. All right, because it's not going to be doing it where you were burned. So if you were burned over a lot of your body, you're going to have some serious issues. A burn occurs when the body or body part receives more radiant energy than it can absorb, resulting in an injury. So again, it's not just about flames, right? Potential sources of heat or potential sources of this energy, heat, toxic chemicals, electricity, radiation, any of those things can cause burns to you. Although a burn may be the patient's most obvious injury, you should always perform a complete assessment to determine whether other serious injuries are present. A big example of that is if you have a patient that is burned to the face, or even if you don't see any major like direct flame style burns, if they have any burns from the neck up, one of the biggest concerns is not really the burn, it's did you do any damage to your airway? If they breathed in superheated gases, um, their airway is going to be burned, right? So their skin may be all scarred up and everything, but that's the least of your concerns. You're more concerned about what's happening inside their airway. Um, if you if you're dealing with a major burn of any type, you definitely need to get a paramedic on scene because they need fluid therapy. They may need an advanced airway. Sometimes paramedics have to do what's called an RSI, where they force a patient to sleep. They'll knock them out, um, and then they'll paralyze them and then put the tube in because they know that the patient needs a tube, but you can't do it if they're awake. They're just going to gag on it. Um, Same thing with us, right? The best airway we can use as EMTs is a supraglottic airway, where you stick a tube down their throat. You're not going past the cords, but you're still going to hit that reflex. So yeah, we get those toys, but again, if they're awake, we can't use them, and so you're still going to need a paramedic at that point. Children, older patients, and patients with chronic illnesses are more likely to experience shock from burn injuries. If they're a healthy adult, the problem can be bad, but it may not be that bad. Pathophysiology for burns. Burns are soft tissue injuries that are spread out over a large area and are created by the transfer of radiation, thermal, or electrical energy. There's a nice little definition for you. Thermal burns can occur when skin is exposed to temperatures higher than 111 degrees, which, if you think about it, is not that hot, right? We're 98.6. We're like 13 degrees off. 111 degrees is like bath water, and it's not that an immediate contact will burn you because it's not that high of a temperature. But if you're exposed to it for long enough, um, it can burn you. The severity of a thermal injury correlates directly with the temperature and the concentration. How much of a area is that temperature being spread across? Amount of heat energy possessed by the object or substance, and the duration of the exposure. Again, if you're talking about something that's like 111 degrees, which is not like that would feel warm to you, but it wouldn't be blistering hot. Um, if you're exposed to it for long enough and the temperature doesn't drop, you could eventually overpower your skin's ability to burn off that heat, and you'll start to cause burns. Burn injuries are progressive. The greater the heat energy, the deeper the wound. People naturally limit the amount of time they're exposed to such heat. It's just a reflex. You touch something hot, you're going to let it go. If clothing is on fire or the person is trapped or unconscious, exposure time can be extended because you don't have that reflex anymore. Some complications. The skin serves as a barrier between the environment and the body. It does a couple things, right? First of all, we all know it protects you from infections that would come in through the skin. Um, your skin also has a hand in how much you either absorb or release fluid from your body. It has a hand in how you control your core body temperature. And all of these things can be affected if enough of your skin is burned, and that's where the problems start to come in. So burns are at a high risk for infection, hypothermia, hypovolemia, and shock. Burns to your airway are of significant importance because the loose mucosa in the hypopharynx, basically just your throat, can swell and lead to complete airway obstruction. If they have breathed in superheated gas, a paramedic is going to really, like top priority, put a tube down their throat because the swelling is going to happen. Like it's coming. The question is do we want to not have the tube in place yet and then not be able to put one in? Because once they swell off, we can't. It's going to wind up being a surgical airway, and that's much worse than just putting a tube down their throat. So get additional resources on scene quick when you're dealing with a bad burn patient. Circumferential burns of the chest can compromise breathing. Circumferential burns of an extremity can lead to compartment syndrome. We talked about that earlier. If you suspect any complications, call for a paramedic. For your burn severity, 5 factors to help determine the severity of a burn. Um, the first 2 are the most important. So, what's the depth of the burn? We talk about, we used to call them first, second, and third degree burns. Now they're called superficial, partial thickness, and full thickness, but they're basically the same thing. They just change the terminology. The extent of the burn, how wide of an area does it cover? Is it just your hand? Is it your entire arm? Is it your entire upper body? That kind of thing. Are any critical areas involved? So your face, your upper airway, because that affects your ABCs, your hands, your feet, and your genitalia. All very important things. Does the patient have any pre-existing medical conditions or other injuries? All right. So again, if they've got um, certain chronic conditions, can be made worse by a burn. Burns to the face are of particular importance. owing to the potential of airway involvement. Burns to the hand and feet or over joints are considered serious because of the potential for loss of function as a result of scarring. For the depth of burns, superficial is your first degree. That's just your top layer of skin. That's your sunburn, your, ow, I touched a hot stove and let it go, but now I've got a little burn on my hand. They're painful, but they really don't require a lot of work. Usually, unless it's a total body, you may want to take them to the hospital for some pain management. But other than that, they're not gonna die from it. Um, Partial thickness. This is your second degree burns, involve the epidermis and some portion of the dermis. Usually these are characterized by blistering. So some sunburns can be this bad, right? I've had the the misery of having a second degree burn all over my upper body because of a bad sunburn that spent too much time out on the Gulf. These burns don't destroy the entire thickness of the skin, um, but they can be pretty bad. These are some this kind of burn is the kind of burn you're probably going to want to start considering doing EMS care for, if it's especially if it's on the more extreme end of the second degree. Typically, your skin is moist, mottled, and white to red. Again, blisters are present, um, and this, yeah, talk about extreme pain. They're gonna be feeling it. And then you have your full thickness burns. These are the worst. These extend through all layers of skin. Sometimes they can even be burning the bone, depending on if it's electrical burn or just how long were they in contact with it. The burned area is dry and leathery. It may appear white, dark brown, or even charred. Um, the nerve endings are all fried, so a third degree burn is not going to hurt. However, all the area around the third degree burn is going to still feel like it's on fire to your patient, because you have your third degree burn, which is surrounded by the second degree burn, which is surrounded by the first degree burn, and they will be screaming, but you can poke a third degree burn with a needle or whatever, and they're not gonna feel that. Significant airway burns are serious, um, because again, now you're starting to run into issues with their ability to breathe, their ability to maintain their airway. So some signs, if you're looking at a possible airway burn, some things you're going to look for is soot in the mouth or the nose. If you see singed hairs, if this is what you're seeing, if you see that they might have inhaled something or swallowed something that's causing major burning, get into the hospital as quick as you can. Get a paramedic to meet you en route if you need to. Any of that kind of thing. So as you can see on the slide, we have what's called, when we're estimating burns, we're talking about the body surface area here for the rule of nines. You're talking about different sections of the body are broken into 9% areas. Um, and then like there is 1% of the body also that makes it that 100%. You have the rule of palms. This estimates the surface area that has been burned by comparing it to the size of the patient's palm, not yours, which is roughly 1% of your patient's total body surface area. So you look at your patient's hand for their palm size, look at their burns, and it's an estimation. But however many palms of their size you think you could take to cover up that burn, that's how many percent their body is. Um, Back on your rule of nines, the proportions are a little different for infants, children, and adults. When you calculate the extent of the burn injury, include only partial and full thickness burns. We're not worried about the superficial ones. So if somebody's got, a mild burn to their chest, but that's it, not concerned about that. Just your second and third degree. Here's your rule of nines. Um, I will say that you don't have to memorize this precisely. However, I actually did have a rule of nines question on the registry. I just only had one. So it's not like they're gonna drill you on it, but you may still see it on the test. So your patient assessment for burns. When you're assessing a burn, it's important to classify the patient's burns. Is it going to be, um, what is it, a heat burn? Is it a chemical burn, electrical burn, that kind of thing? And then depending on what it is, that will change some of your your index of suspicion as to what's being hurt. If it's electrical, you know that the damage inside the body is going to be pretty much just as bad, if not worse, than what's on the skin. If it's a heat injury, mostly your skin is going to be what's involved, unless it's a full thickness, that kind of thing. Worry about the depth of the burn and the severity, as far as is it superficial, partial, or full thickness. Your scene size up, your actual assessment goes the same. So BSI, scene safety, determine your mechanism of injury, make sure that you can actively get to your patient and take care of them without getting hurt. If you're still in a dangerous environment, but you can reach your patient safely, get your patient, move them to a more stable environment and start your patient care there. Begin your rapid exam for your primary assessment. So focus on your ABCs, get your general impression, all that stuff. When you're doing your airway, take a look inside their mouth, see if you see any signs that they may have gotten any burns in there. So remember, we talked about the soot, the swelling, all that kind of stuff. Be alert to signs that the patient has inhaled those hot gases or vapors. Heavy amounts of secretions and frequent coughing may indicate a respiratory burn. So if they're constantly coughing, trying to cough something up, that's usually your sign. Quickly assess for adequate breathing. Don't spend a lot of time on this. Just, make a quick decision. Does it look right? Does it look adequate or not? And then inspect and palpate the chest wall for your DCAT BTLS. For your circulation, they tested me on this one. Yeah, they do put it on there. They just don't give you a lot of questions on it, unless that's the part you're struggling with, and you're going to get more of those questions. Quickly assess your pulse rate and quality. Determine perfusion based on the patient's skin condition. So again, you have that cool, clammy. Obviously, you're not going to see cool and clammy on a burn, but look in a non-burned area and see what the normal skin looks like. Take your steps to control significant bleeding if they have it. You usually won't get significant bleeding from the burn specifically, but if trauma is involved, you will probably have that as well. If the patient has obvious life-threatening external hemorrhage, control the bleeding first. The burns can be treated later. Treat for shock and burn patients by preventing heat loss. Cover the patient with a blanket. And for those of you that are getting ready to move on to higher levels of care, we have what's called the Parkland formula. Our biggest concern for burn patients from an ALS standpoint is fluid replacement therapy. If their burns are bad enough, they're going to be losing a lot of fluid. So you're going to see your paramedic is working on pumping them full of saline. So that being said, from the basic point of view, you're going to be treating like they're in shock. You're going to cover them up. If it's, well, I'll tell you what, we'll talk about that when we get to actual wound care. Because some burns you want to cover them up to keep them warm. Some burns you really don't care about that. It just depends, and we'll talk about that when we get to it. Make your transport decision. If anything is compromised their airway, they're going to be a high priority. If it's anything other than a superficial burn, they're going to be a high priority. If it's a lot of body surface area, high priority. If it's a scenario that we give you, high priority. Investigate your chief complaint, just like always. If they tell you, "Ow, I've burned myself," don't start poking and prodding around an unaffected ankle looking for broken bones. That's not what they're complaining about. Be alert for signs or symptoms of other injuries due to the MOI. If the patient was burned in a confined space, suspect an inhalation injury. And when burns result from explosive forces, be aware that they may have other injuries from that explosion. Typical signs of a burn: you have pain, redness, swelling, blisters, and charring. That's progressively worse, right? If you just have pain and redness, that's your superficial. Swelling typically tells you that they have some injuries below the skin because now their body's trying to send fluid to it. And charring is your third-degree burns. Regardless of the type of burn injury, stop the burning process. If they're still actively burning somehow by the time you show up, they've burned long enough. You can put some water on them or something at that point. Apply a dressing to prevent contamination and then treat the patient for shock. Get your sample history, which we already talked about before. I'm not going to drill you guys twice in the same night. Check whether the patient has an emergency medical identification device. Again, look at their phone if need be. If they're awake, just ask them. For your physical exam, perform an exam of the entire body. Here's the thing, when they are burned, they're probably only going to be focusing on the worst burn, but we want to know if they have any more, especially if it's something, say, like a chemical burn from a hazardous material, because not only are we worried about the burn, we're also worried about contaminating other people, including ourselves. So do a good head to toe. Just focus your search on their chief complaint. Like I said, still going to be doing decap BTLS, but if it's a burn patient, I really don't expect you to dig around for deformities unless it was like a car accident or something. Um, Focus on what the problem is. Make a rough estimate using either your rule of nines or your rule of palms, whichever you are more comfortable with, of how bad or how wide of an area they're burned. Determine the severity of the burns, package your patient for transport based on your findings, and get them to a hospital. Remember, when you assess their respiratory system, don't just look in their mouth. Get some good lung sounds. Look, listen, and feel. Look for that chest rise. Look for soot around the mouth, the nose, singed nasal hairs. And if any of those findings are present, open the patient's mouth and examine for burns or swelling of the tongue. Ask the patient to cough and assess for black sputum. If you see that, usually that means they've inhaled smoke. Listen to breath sounds with the stethoscope. And what you're listening for when you're listening for breath sounds is going to be fluid accumulation in the lungs, because whatever they've burned, the body is going to start trying to fix it. And that means sending fluid to the area, which can be a major problem, which we'll talk about when we get to, we start talking about what we're going to be doing for different types of burns. Assess your patient's neurologic system. So get their level of consciousness, look at their pupils, motor response. Can they feel you? Can they squeeze your hands? Can you get a pulse? That kind of thing. And then reassess. All right. So now for the fun part of burns is, what are we going to do about them? First thing we need to do, and again, I know it sounds stupid because when you think about stopping the burning process, you think about flames. That's pretty self-explanatory, but remember that your patients can be burned from different things. So step one, stop the burning process. If it's a chemical, we got to get the chemical off of them. And we talked about that already, about how we would do that. Copious amounts of water, before you start dousing them. Brush, if it's a powder, brush the excess powder off, then douse them with water. Um, but the important thing is to stop the burning process and then prevent additional injury. What we do from there really just depends on how bad they're burned. So this is breaking it down by the types of burns, but I'm going to do this a little bit differently. I want you to think more about how bad is that burn. If it's a superficial burn, we're really more concerned about pain management, which we can't do with medicine at least. But what you can do is put some cool water, a moist, wet dressing, something of that sort on their burn. That will help make the burn feel a little bit better. All right, so wet dressing, superficial. When you're dealing with a partial thickness, depending on, unless it's a life threat involved, like partial thickness around their face, still going to do the same thing. We're worried about pain management. We're going to be worried about some other things too. You have a heightened suspicion, but you can still use a wet bandage for partial thickness burns. That's all right, because the part of the skin that controls their core temperature is deeper. Usually that's not affected by a partial thickness, so it's okay. We can use a wet bandage. If it's a full thickness burn, if it's third degree, now we're talking about the inability of the skin to do its job, period, which includes temperature regulation. So we don't want to put a wet bandage on a person with third degree burns. Their body's not going to be able to regulate their temperature, and if we throw water on them, either directly or with a bandage, we just made it that much harder for them to stay warm, pretty much impossible at that point. And our patient's going to suffer from hypothermia from a burn, which I know that's kind of counterintuitive, but the problem there is we caused it. So we don't want to do that. If it's a mild to a moderate burn, we can use a wet dressing. If there's third degree, full thickness, dry dressings keep them warm. All right. So that being said, let's look through this and see if any of these things, if there's anything we need to add. We know what thermal burns are. That's the common burn that we think about coming from a heat source. Steam burns. The biggest problem with steam is that it's a high risk of inhalation. So if it's a steam burn, you're going to worry about their airway. Talked about how to manage those based on the severity. Inhalation burns. Mostly with inhalation burns, we're worried about the airway. So inhalation injuries occur when burning takes place in enclosed spaces because they're going to breathe in those fumes. They don't have any exhaust, nowhere for those superheated gases to go. So consider requesting ALS backup. Please do, because they're going to need an airway, one beyond what you have the ability to give as an EMT. When you're dealing with inhalation burns, it's not just the burn. You're worried about some of the gases that they've breathed in. Firefighters, reason why we wear SCBA, and unfortunately our patients obviously don't. Nobody keeps a pack in their house. It's because there's a lot of bad crap in the smoke that we breathe that's in those environments, right? It's not just carbon monoxide. We always think about that being the bad juju, but if you think about what's burning, like, I got a couch behind me made completely out of synthetic fibers. Um, you're going to have hydrogen cyanide, hydrogen sulfide. Um, Obviously, you are, yes, you're going to have carbon monoxide, but there's a lot of stuff that you can breathe in from black smoke that will kill you in a heartbeat. Most of the time, the patients that we lose in house fires, they died from the smoke before the flames ever got to them. So that's kind of the big problem there. And if you have a patient that is still alive and you're worried about that when you bring them out of the house, keep that in mind that they're going to have all these gases in their system if they breathed in the smoke. You got them out of the house, they may still die on you. It sucks, but it just depends on how much of it they breathed in, and then what can you do about it. So give them lots and lots of oxygen. These are some of those exceptions to that whole 94 to 99 rule. If you pull a patient out that was breathing in smoke, just flood them with oxygen, because the free radical issue is not as bad as them not getting enough oxygen. Care for any toxic gas exposure includes recognition, identification, and supportive treatment. So give them a lot of oxygen, but get a paramedic there. Chemical burns, usually those are going to be superficial depending on how long the chemical is on the body. If it's in the eyes, that's a problem. And if you have to irrigate the eyes, the big thing there is make sure that the bad eye is down. So when you turn their head to irrigate it, make sure that you're irrigating the bottom eye. You don't want the good eye having the runoff go into it. Now they got two bad eyes. So for chemical burns, the severity is directly related to a couple of factors. Type of chemical, is it an acid or a base? The concentration, are we talking about pure bleach? Are we talking about watered down bleach? Acids, that kind of thing. And then how long has it been on them? The longer it stays, the more it's going to do damage. Wear appropriate chemical resistant gloves and eye protection so that you don't get it on you, because you don't want to get burned as well. How this happened, I have no idea, but that looks like lime on that guy, which is a strong, strong base. Um, that's a very caustic issue. And if you notice, what they're doing is they're using a dry bandage to wipe it off of them first, just so that all the excess, or at least as much of it as they can get, the excess is gone. Then they're going to flood them with copious amounts of water, being a keyword there. I know every time they put that question on the registry, they've used the word copious. So if you see that, it's probably your answer. Um, you're basically just going to douse a guy with a whole lot of water for like 15 minutes. It's a lot of water. Just turn the hose on, turn a fire hose on, and just let them sit there getting flooded out by an inch and a half or whatever. Um, you need a lot of gallons. Don't use a little bit of water, because depending on what that chemical is, it could be water reactive, which means that when it gets wet, it's going to create heat. You got to get it off of him. Water's the way to do it. You just want to use enough that you get it off fast, so that he's less time with that burn on him. All right, for electrical burns, these are the ones that really suck, because they go right through you and they burn everything in their path. Electrical burns may be the result of contact with high or low voltage electricity. High voltage burns may occur when utility workers make direct contact with power lines. Usually they don't even realize they got shocked. They just, whatever comes next, that's where they're at. And they're like, how did I get here? Ordinary household current can cause severe burns and cardiac arrhythmias. Let me ask you this. If you were to come in contact with a direct energy flow, which one do you think is worse for you, the AC or the DC? Alternating or direct current, which one is worse for you? AC. Yeah. Okay. Why? And you're right. You're right. I'm not saying you're wrong, but just, why is AC worse than DC? Yep. Yeah. Well, they're both gonna shock you. Um, but yeah, you're absolutely right. So AC is an alternating current. So think of it as just waves. Every time it would go to blow you off of it, um, when the shock comes back around, or when the wave comes back around, it pulls you back in. It holds you there. So you're gonna get stuck to it, and until something knocks you loose, you're continuing to get shocked. Um, DC doesn't have that return. It's either there or it's not. It's like an on off. So when it pops you, it throws you. You're going to get knocked away from it, and then the shock is over. They're both bad, but AC is worse because if you get caught on that current, you're not going to let go of it, or at least you're the muscle that's contracting to it is not going to let go. That's why one of the reasons why we teach firefighters when they're waving their hands along a wall, if they can't see in a house fire, to use the back of their hand. Um, the misnomer is that it's because you don't want to burn your palms. But if you're wearing your fire gloves, you're not going to burn your palm. You're really not touching anything to do that. But your gloves are not electricity proof. So if you're, as a firefighter is going along, they're rubbing their hand along the wall of a room that they can't see in to try to stay where they're at, and they're looking for windows and doors and all that stuff. If they come across an exposed wire and it catches them, if it's the front of their hand that catches it, and houses are AC current, so this is where this would happen. Their hand's going to grip closed, and now they're going to be grabbing the wire, and they're not going to let go of it, and they're stuck. But if it's the back of your hand you can't grip backwards, right? Your hand's going to it's just basically open up, so you're much more likely to be able to get off the wire without getting stuck on it and fried to a crisp. But anyway, I digress. For electricity to flow, there must be a complete circuit between the source and the ground. We have insulators and conductors. Your insulator is any object that prevents the circuit from being completed. Rubber is a fantastic insulator. Conductors are any surface or substance that allows a current to flow through it.
I think I'm gonna go upstairs.
Brass, metal, copper is a fantastic conductor. Gold's a fantastic conductor, and so is the human body, sadly. Um, the type of electrical current, magnitude of the current, and voltage have effects on the seriousness of a burn. Obviously, the higher the electricity, the worse it'll be. And again, it's not just about skin. We're not talking about heat burns here. We're talking about electricity that's going to pass through you. So it's going to burn all the organs that it comes in contact with until it leaves you and goes to ground. I actually have a buddy. I say he's a buddy. I hadn't seen him since I was a kid, but he got electrocuted, and the exit wound where the electricity jumped out of him and into the ground was about 6 inches up his leg, and there's a giant, what used to be an actual hole where it blew out a portion of his leg on the way back into the ground. Um, he has since healed up, but he's got a pretty gnarly scar where that used to be. The thing about electrical burns, your safety, like it says on the side, your safety is important. If they're still actively being electrocuted, don't just walk up and grab them. If you see somebody get caught on an AC current, if you try to grab them and pull them off of it, you're going to join the circuit. Now you're getting shocked as well. So the alternative, you have a couple options. Ideally, you just shut off the electricity, and now you don't have a problem anymore. If you don't have that option, don't grab them and try to pull them off of it. Actually hit them. Treat it like it's a football game and you're going to tackle them. Just get a good run and start. Let your momentum hit them. You can use something that is got an insulator built onto it. So like if you rubber tools, for example, you can use the tool to knock them loose, but because it's rubber, The rubber is an insulator. It will hopefully insulate you from the circuit so that you don't join it and you don't get electrocuted as well. A lot of it just kind of comes down to what you have at your disposal and whether or not you can access the panel to shut off the electricity. We talked about the dangers, deep tissue injury, problems with their organs. You also have the issue of your heart because your heart is operated by electricity. If you get electrocuted, you run the risk of throwing your heart into some dysrhythmias that will lead to cardiac arrest because you messed up your electrical rhythm. So here's an example of an electrical burn. Looks like the exit wound where it came out. In fact, that's the bottom of a foot. So that's where the electricity left the body. I'll leave that one up for a minute. So with electrical burns, consider the other damage that's been done. Don't worry about the burn if your patient's in cardiac arrest. Do CPR. Then worry about the burns. Tasers. In recent years, law enforcement has increased its use of tasers. Tasers are not non-lethal. That is the wrong term. So if you've ever heard somebody say that, they use non-lethal means, tasers don't kill people. No, tasers can kill. Tasers are technically considered less than lethal, which means that they're not expected to kill, but they can. Like if a lethal weapon would be like a gun, right? If a cop's going to shoot you, you're expected not to live. Like that's why they a lot of times they tell you like, when do you know when to stop shooting? If you ever have to pull your weapon and shoot somebody, it's when you run out of bullets. Because that's the whole reason that you're shooting them is to end whatever it is that they're doing. Um, but for tasers are not meant to be lethal. They're less than lethal. They just understand the people that make it understood that some people with electrical issues with their heart, for example, underlying issues, the cop's not going to know your medical history when he tases you. He's just tasing you to stop you from endangering him, others, yourself, whatever. If you have a bad heart, he doesn't know that, and there's no way to know that. So you, as an EMT, may have to respond to that. I had to respond to a kid at my local high school that got tased twice in the same day by the SRO. He's no longer the SRO, but I mean, it still happened. Um, Thankfully, he didn't have those issues. But every time somebody gets tased, typically um, EMS is going to have to roll out to make sure that the patient is okay. There are some potential complications for patients when these devices are used, like excited delirium. Um, Excited delirium is a true emergency and warrants assisted ALS response. A lot of times, illegal drug use is involved with that. Using a taser device in patients with true excited delirium has been previously associated with dysrhythmias and sudden cardiac arrest. So, if these are the people that get tased, and usually they do because the cop needs to protect either, like I said, himself or others. A lot of times, there's some problems with their heart after that. Make sure you have access to an AED when you respond to patients who have been tased, because a lot of the reason that they're having those heart issues is because their rhythm's messed up. If the rhythm is either VTAC or VFib, an AED will fix them. A few of the ambulance companies around, the policy is they will remove the prongs from the tasers. They will check the patient, but not remove them. Around here, okay. So a few of the ambulance companies around here is they will remove the prongs. I'm assuming remove the prongs from the tasers. They will check the patient, but not remove. So wait, are they removing the prongs or not? They won't remove the prongs. Okay, no, and that makes sense, right? Because um, you want to still be able to use that. The taser still needs to be used if necessary. If your patient decides to get combative with you, the cop can just pop them again. So the prongs, yeah, I can see that prong staying in place. And it really is. It comes down to your local policy. All right, for your radiation burns, acute radiation exposure has become more than a theoretical issue because the use of radioactive materials has increased in industry and medicine. Usually, we don't use enough to cause issues, but I mean, if equipment malfunctions, if a If a barrier that's supposed to dumb radiation down to an acceptable level, if the barrier breaks, then you have the risk of being overexposed. If you happen to live in Russia, well, who knows? But um, potential threats include incidents related to the use and transportation of radioactive isotopes and intentionally released radioactivity in terrorist attacks. So terrorist attacks are a real thing. We do transport radioactive material on our roads. We don't carry nuclear warheads across the country. We can't fly it over American soil, that kind of thing. But that doesn't mean we don't carry just nuclear waste or any radioactive materials in general. We use radioactive material in a lot of hospital equipment, your microwave. Any of these can cause some radiation poisoning, especially the old ones. I don't know if y'all were ever told the same thing. When I was a kid, I remember being told not to stand within like 2 or 3 feet of my microwave when it was going because I might get radiation poisoning. Whether that was true or not, I don't know, but I'd rather not find out. There's three types of ionizing radiation. You have alpha, beta, and gamma. There's also the neutrons, but we don't deal with those at this level. So, if you guys ever go to like a military CBurn course, you're going to learn about the neutron as well. But we just deal with three here. Your alpha particles and your beta particles, they are solid objects. They're like dust. Alpha does not really do anything to you. Your clothes can stop it. It's not a big deal, but it is dangerous if you ingest it. So if you're in an area that's got alpha particles floating around, put on a mask or something of that sort so that you don't get it in your mouth. Beta particles, they do have greater penetrating power. They're smaller and they're more radioactive, but they're blocked again. Or I'm sorry, the alpha is blocked by the skin. The beta is blocked by clothing. So if you don't have to be in like fire gear or any kind of radioactive suit to protect yourself from that. But your gamma rays, these are also known as X-rays. They're very penetrating. They'll go right through you. They'll go right through your clothes. Typically, it takes lead or a few feet of concrete and dirt, that kind of thing, will block gamma radiation, but it takes a lot of it or something very, very, very dense to stop those rays from getting through. Because they're not solid objects, the gamma radiation is just a ray. It will pass through things. Most ionizing radiation accidents involve gamma radiation, which is your X-rays. People who have sustained a radiation exposure generally do not pose a risk to others, but in incidents involving explosions, patients may be contaminated. If you've ever heard of a dirty bomb, that's what those are. Um, but it's not contagious. So if you've got a patient that's got radiation poisoning, it's not like you're gonna get hepatitis from. It's not something you're not gonna get. They're not producing the radiation. They're just affected by it. So you don't have to worry about your patient giving you radiation poisoning. But if you're in the area that gave them radiation poisoning, well, then yes, you might get it as well. All right, for management of radiation burns, maintain a safe distance and wait for the hazmat team to decontaminate the area or the patient before initiating care. Because again, your alpha and your beta particles are solid objects. If it's on your patient, you can get it on you. But those are the small things. You're not really gonna just don't get it in your mouth. Most contaminants can be removed by simply removing the patient's clothes, pour some water on them. Once there is no threat to you, you can begin treating ABCs and treat the patient for any burns or trauma. Irrigate open wounds, because again, you're dealing with basically something that the longer it's on them, the more it's going to affect them. Notify the emergency department before you even leave, because if the ER can't accommodate the patient, you're not going to be able to go there. So as soon as you know that that's what you've got and you know where you want to bring them, contact that ER to notify them that you're coming and give them the opportunity to prepare, of course, but also to turn you away just in case there's nothing they can do. You may have to go to a different hospital. Identify the radioactive source and the length of the patient's exposure to it. And limit your duration of exposure as well. So there's three things to protect you from radiation. We joke about in the military, we call them STDs, right? So you have your time, your distance, and your shielding. The less time you spend in it or just get away from it, That's good. Your distance, the further away you are from the source, the less it's going to affect you. And then your shielding, we could, like I said, depending on what it is, you can use your clothes may be enough. You may actually need a suit. It just depends. All right, for your dressing and your bandaging, we're going to skip this portion because we're going to go all over this when we go to the boot camp. Like the entire day is going to be spent doing this and splinting and so on and so on. You're going to be masters at this. There's really no sense in talking about it over slides. So that actually concludes the lecture for the night, which is perfect timing because it's almost time for the next break. So we'll get through these. And then let me get actually, I already made your pin. So your pin for the night is going to be BC, Bravo Charlie, 26, and then S as in Sam, Sierra, whatever you want to say. BC 26S. Does anybody have any questions? Any questions about the material? Any questions about actually, I'm going to go ahead and stop the recording for that portion. But does anybody have any questions about the